Good morning, everyone. Just following up on my previous video about sensitive fillings. Also, if a dentist coming with a complaint that they're having patients complaining of their crowns getting sensitive after insert, there are few things that I think will help to avoid this problem from happening in the future. But again, first, I will leave you with a better view first. So for credibility, my name is Khaled. I'm a dentist in Queensland in Australia. I've been a dentist in private practice for 20 years. I own my own dental practice. I started as a solo practitioner and I grew my practice into a 10-chair practice with a team of 40 members. And I have been dealing with new graduates for many, many years in my practice. So answering the crown prep or the crown insert sensitive problems, very similar to the fillings if you're doing a filling inside the crown prep, but most commonly, again, if your crown prep is taking way too long, number one, you're exposing the tooth to too much saliva and too much trauma. If you're stopping, you're putting your handpiece down and blowing air to check every step you take, every few minutes, the pulp or the nerve doesn't like that. Doesn't like air blown into it on freshly cut dentin all the time. So my advice again, depth cuts, follow the depth cuts, put your handpiece once you finish your occlusal, your buccal, your palatal, your lingual, and your proximal reduction. Finish your overall reduction first before you put the handpiece down and check. Once you do that, you put your handpiece down and check, and then go back and define the margins. Minimize the amount of the exposed dentin. Then from there, you can decide to do immediate dentin sealing or jump straight to impression or scanning. Always isolate as much as you can. If you can isolate with rubber dam and you finish your prep, put a lot of cotton rolls when you're scanning or taking impressions. Minimize any chance of saliva getting into the fresh dentin, especially if you're not doing immediate dentin sealing. I think one of the most common problems with sensitive crown insert are due to the temporary. If your temporary is high in occlusion, patient will come back with post-operative sensitivity. And also if your temporary is leaky and is not sealing around the margins really well, you will have post-operative sensitivity. If you're using like immediate inserts like with CEREC, you won't have these problems as much. The third most common problems that cause sensitive crowns, and probably even with experienced dentists, is occlusion. Make sure you check the occlusion before you start your crown prep. Take photos of where the markings are, especially if you're a beginner. Just try to mimic that. Photos of the marks in centric, photos in eccentric, photos in protrusive. Very, very important. Now, when you insert your crown, you want to mimic those occlusal contacts as much as you can. So it can be very hard when the patient is numb. So sometimes you might need a second appointment when the patient is not numb to adjust the occlusion again if required. So it's very important to check the occlusion and try to mimic what the patient had before, unless you're doing a massive occlusal changes in the patients. Check centric separate, then adjust. Once you're happy with centric, check eccentric, then check protrusive. Do not check centric, eccentric, and protrusive at the same time. Another point is lower 7 and upper 7s can be a headache to deal with. There's an article I will share in the comment. It's not, I didn't write this article, by Dr. Michael Melkers in the US. One of the best articles I've seen on how to treat upper and lower 7s and how it can affect the occlusion. So I will post the article because he will describe it much better than me. The last thing, of course, is bonding. I rely a lot on using zirconia crowns and cementing them with Fuji Plus or glass ionomer cement. But if you're relying a lot on bonding, make sure you communicate with your lab thoroughly who's doing the hydrofluoric acid etching, who's doing the silane, and then you can do your bonding in-house. I prefer, if you're bonding your own ceramics, is you do the hydrofluoric acid etching and salinating in the practice, and then following your bonding protocol using Gluma and dual cure cement would help as well. For me, if I want to have like one point that would probably be the most common point for post-operative sensitivity, I would bet on occlusion. Occlusion has been ignored, or occlusion hasn't been managed or adjusted properly. If you have any questions about that, please let me know, and I hope this video is helpful for you.